Hello, everyone, and thank you for joining us today. My name is Carla Alegria with the National Center on Domestic Violence, Trauma, and Mental Health. Today's webinar is on substance use, trauma, and domestic violence, critical issues, promising approaches. Today's presenters are Dr. Carol Warshaw, Director of the National Center on Domestic Violence, Trauma, and Mental Health, Lori Thompson, the Health and Behavioral Health Coordinator with the West Virginia Coalition Against Domestic Violence, and Beth Collins, the Domestic Violence Program Specialist with the Colorado Department of Human Services. And briefly introducing her program is Christina Principe, Program Specialist with the Family Violence Prevention and Services Program. Before we get started, I would like to go over some technical details of the WebEx software that we'll be using for today's webinar. Many of these details are explained on using this Webinar System tab in the center of your screen. You can switch the screen from the slides by clicking the down arrow next to using this webinar. Please be aware that your screen might look a little different depending on whether you're using a Mac or PC. On the right-hand side of the screen, there are multiple boxes. Third from the bottom is the chat feature. You may have to click on the chat cloud icon at the bottom center of your screen to open your chat box. This feature will allow you to provide feedback and share resources with your fellow colleagues, as well as get in contact with the trainers or myself if you have questions regarding the training content. You may contact Angelica Medina, also at the center, if you have questions troubleshooting the WebEx software. To do this, click the down-facing arrow and select the person you would like to contact. You'll see a lot of options, but for this session, you'll want to select all participants if you would like to respond to a question from the trainer or to contact the center staff anytime during the session. You should click on Angelica Medina to privately contact her if you are in need of troubleshooting the WebEx software. So let's test this chat feature. Will everyone please go to the chat box, click on All Participants, type in where you're calling from, and then press Enter. Perfect. Thank you all very much. While folks can get a lot out of the chat feature, there are times when it moves really quickly and can feel distracting. If this is true for you, feel free to minimize the chat box by clicking the arrow next to where it says Chat. You can always open it again with the same arrow if you choose. We will be providing live captioning during this session. Below the chat box, there is a Media Viewer box. This will contain the captions. If you do not want to see the captions, click on the down-facing arrow next to the word Media Viewer, the same way you might if you want to hide the chat box. Time permitting, I will be moderating the Q&A towards the end via the chat box. And at the very end of the webinar, you'll be taken to a brief survey. Please take a moment to let us know what was useful and what could have been better. If you get disconnected at any point, return to the email you received with the original webinar link and re-enter the training. Sometimes the sound cuts out due to internet connection, so feel free to call back in if that's a problem for you. If you're experiencing technical difficulties and are unable to contact Angelica Medina, you may contact WebEx Tech Support to resolve any issues. That phone number, which I'll post in the chat box, is 1-866-229-3239. Again, thank you all for joining us today. I will now turn it over to Christina.
Good afternoon, everyone. I am Christina Principe, Program Specialist with the Family and Youth Services Bureau, Family Violence Prevention and Services Program. We're also known as FVPSA. We're housed in the Administration for Children and Families at the Department of Health and Human Services. So first, I'd like to acknowledge that, as many of you know, October is Domestic Violence Awareness Month, and we also refer to that as DVAM. DVAM evolved from the Day of Unity that was held in October of 1981 and was conceived by the National Coalition Against Domestic Violence. The intent was to connect advocates across the nation who are working to end violence against women and their children. So in observance of DVAM, FVPSA and the Office on Violence Against Women and the Department of Justice would like to welcome you all today and thank you for joining us to learn more about the important intersection of domestic violence and substance use coercion when working with survivors. Research has shown that survivors of domestic violence are at greater risk for experiencing a range of substance use disorders and mental health conditions such as depression, PTSD, and even suicidality. Given the current opioid crisis, these conversations are critical when working with survivors and planning for their safety. We'd also like to express our sincere appreciation for the National Center on Domestic Violence, Trauma, and Mental Health and their groundbreaking work and dedication around considering substance use coercion in the context of safety for victims of domestic violence. And now I will present to you Dr. Carol Warshaw. She's the director of the National Center for Domestic Violence, Trauma, and Mental Health.
Thank you, Christina. So we're delighted to host this webinar on substance use, trauma, and domestic violence in partnership with OVW and the Family Violence Prevention Services Program in honor of DVAM. Today, I will be presenting a framework for thinking about substance use in the context of trauma and domestic violence and the implications for policy and practice, particularly in the face of the national opioid epidemic. Lori will talk about the experience in West Virginia from the coalition's perspective on issues facing survivors in programs in a largely rural state heavily impacted by the epidemic, and some of the innovative approaches programs and communities are taking to address them. Beth will be talking about a wonderful project that involved the adaptation of seeking safety by DV programs in Colorado to support survivors who are also dealing with trauma and addiction. As Christina highlighted, we're one of the 4 special issue resource centers funded by FIPSA, and addressing the intersection of these complex issues and trying to support the domestic violence, mental health, substance use, and child welfare fields in creating what we call accessible, culturally responsive DV and trauma-informed services and organizations, and to foster cross-sector collaboration. You can see we do this through an array of training, technical assistance, resource provision, research evaluation, policy, and public awareness. So given that, I'm going to start our conversation. Now, I'm just making sure I have the technology. Okay, so why think about substance use in the context of trauma and domestic violence? What are the connections and what do they mean for our work? As Christina said, we've known for a long time, and research has consistently documented that abuse by an intimate partner increases a person's risk for developing a range of trauma-related mental health and substance use conditions. And as you see, we're focusing on depression, PTSD, suicidality, chronic pain, and substance use, including opioids, in part because they're highly interrelated. That PTSD and depression are risk factors for subsequent substance use, as is chronic pain, and substance use itself can be a risk factor for depression and for chronic pain when people are going through withdrawal. Not surprisingly, research has also documented high rates of domestic violence among people seen in substance use disorder treatment settings, including methadone treatment programs, as well as high rates of substance use among people seeking DV services, underscoring the need for more integrated approaches to substance use in DV. Studies in both substance use treatment settings and DV shelter settings indicate that up to 2/3 of program participants are dealing with both domestic violence and substance use. Less well recognized, however, are the ways that people who abuse their partners engage in abusive tactics targeted specifically towards a partner's substance use or mental health as part of a broader pattern of abuse and control, tactics that referred to now as mental health and substance use coercion. For example, while a survivor of domestic violence may use alcohol or other drugs to cope with emotional trauma or chronic pain, they may also be coerced into using by an abusive partner who then controls their supply and then in turn uses their substance use or subsequent addiction to further their abusive control. Surveys that we conducted in partnership with the National Domestic Violence Hotline found very disturbingly high rates of this type of abuse. Although survivors have reported these tactics for decades, these surveys provided the first large-scale quantitative data on the issue. And so what we see, the study, for those of you who aren't familiar with the focus surveys that the National DV Hotline does at the end of a call if someone isn't in crisis and agrees to participate, mostly because they want to help other survivors, then there's a brief survey around 5 questions. And what we found, and this was over 3,000 callers, not callers who were in substance use treatment or who were identified as having any kind of problem with substance use. 26% said that they had used substances to reduce the pain of partner abuse, and to cope with that. But 27% said that they'd been pressured or forced to use substances by a current or former partner. And what we heard when people were talking to the advocates who were conducting the survey, that there was a continuum. Some people felt pressured to use and felt like they couldn't refuse. Others were threatened and coerced into using. Some were literally physically forced to use, and others were drugged. We also found that of the 15% of callers who reported trying to get help for their substance use, 60% reported that their abusive partner tried to prevent or discourage them from getting that help. And again, there was a continuum: preventing access, making sure that people didn't have the resources to get their transportation or child care, trying to control a provider's perceptions of their partner, and harassing them out of treatment, calling continually till they finally left, or keeping drugs and alcohol in the home after they got home from rehab or treatment. In addition, more than a third of the callers said that their abusive partners threatened to report their substance use to authorities to keep them from getting something they wanted or needed, such as a protection order or custody of their children. And again, they might threaten to report, they might actually report, and they made false allegations. We've heard stories of abusive partners coercing their partners into using or literally drugging them, videotaping them, and then when they're high or incapacitated, using that against them in a custody case. Finally, nearly a quarter of the participants reported being afraid to call the police for help because their partner said they wouldn't be believed, or because they would be arrested for being under the influence. Although we didn't ask explicitly, callers also reported numerous instances of substance use-facilitated sexual coercion. That coercion into using substances to enhance their partner's sexual experience, being pressured, coerced, or literally drugged. So again, when we step back and look at this all together, we see a very disturbing pattern. So not only are survivors experiencing the traumatic effects of abuse using substances in response to trauma, their partners are actively undermining their sanity and sobriety and parenting, controlling their access to medication and treatment, sabotaging their recovery, and then turning around and using it against them to discredit them with potential sources of protection and support, such as friends, family, helping professionals in the courts. And when we talk to custody judges, when they're making determinations, how are they going to decide based on, the one person looking much more well put together than the person that they've been abusing for years. So these forms of abuse not only compromise survivors' ability to engage in treatment, but also make it harder to access DV services, to maintain custody of their children, and to access protection through law enforcement or the courts. And one of the things that's so disturbing is it's the stigma, in part, associated with substance use and mental health conditions that contributes to the effectiveness of these tactics and creates additional barriers for survivors and their children when they seek help. And we know that abusers will leverage stigma and any kinds of punitive policies against their partners. So how does this relate to the opioid epidemic? While trauma and opioid use in DV are clearly intertwined, there's been little attention paid to the potential role of DV and substance use coercion in people's use of opioids and opioid-related deaths, issues that are critical to consider in the development of strategies to address the epidemic. Some of the things, specific forms of coercion, coercing in addition to the types that we talked about already, forcing or coercing a partner to use unsafely, to use dirty needles, where needle exchanges might be part of safety planning, forcing a partner into withdrawal, which is a powerful threat, as many of you know, that people, once they're addicted, use to prevent themselves from going into withdrawal, and that becomes a tactic of a control and a way of coercing a partner to engage in illegal activities, including dealing drugs, theft, and prostitution. And when we think about the reasons why women are incarcerated, it's usually one of those three reasons. So again, thinking about another issue that comes up is stalking. When someone's accessing methadone treatment where you keep regular appointments every day, it makes it easier to be stalked. So it's thinking about all of these issues together as we're developing strategies and policies. Oh, I just got a text. I should speak slower, so I'm going to try to do that. I'm going to ask you to take a step back and keep in mind the role of coercion and DV and the use of opioids as we consider the current discourse on women and opioid use and the research highlighting gender differences in opioid use and addiction. And so while there have been efforts to examine the opioid epidemic through a gender lens, what's been missing is the gender-based violence part of the analysis. I'll refer you to our first webinar in this series where we looked at the intersection of gender-based violence and historical trauma in the role of the opioid epidemic in Native American communities, and also issues around the SAVA epidemic, syndemic of substance abuse violence and HIV/AIDS. So we know that women who've been diagnosed with opioid use disorders are more likely to have experienced multiple types of gender-based violence, including DV. They're more likely to have been prescribed opioids for chronic pain, be given higher doses for longer periods of time, and more likely to self-medicate to cope with trauma. They're also more likely to initiate hazardous use, particularly after initiation by a romantic partner. Less well-studied, we also know that lesbian, gay, bisexual, and transgender survivors are also at greater risk for depression, PTSD, and opioid use, often in addition to abuse targeted towards their gender and gender identities. However, women are also physiologically more likely to become addicted in a shorter period of time. This is called telescoping, and to experience more craving and more severe health consequences from substance use. These factors increase women's risk for addiction, medical complications, overdose, and death, all of which are likely to be amplified in the context of DV and substance use coercion. Another important step forward in the discourse on the opioid epidemic and substance use in general is the growing understanding of the neurobiology of addiction, the move from addiction as a moral failing to a brain rewiring. Research has begun to identify how our brains and neural circuitry are altered by exposure to addicting substances, including how those altered pathways are activated in response to relapse triggers. These include exposure to addictive and rewarding drugs, condition cues from the environment or reminders, and exposure to stressful experiences. Again, what hasn't been factored into these conversations is the potential role of substance use coercion in these processes and how these circuits can be deliberately activated by an abusive partner. One more public policy concern related to the opioid epidemic that's been receiving a lot of attention or particularly salient in situations where women's use of substances is met with more punitive responses. For example, the use of opioids during pregnancy and increasing rates of neonatal opioid withdrawal syndrome, or NOWS, has become a major public policy concern. Medication-assisted treatment, not opioid withdrawal during pregnancy, is associated with the best outcomes for women and their newborns. And there's also clear evidence demonstrating that supporting the mother-infant bond and attachment shortens the course of NOWS and improves infant well-being, and that women are more likely to enter treatment, stay in treatment, and maintain recovery if they remain with their children. Yet opioid use during pregnancy is still considered child abuse in 23 states plus Washington, D.C. Helping women to navigate this terrain has become an essential component of both advocacy and clinical practice, and including by major medical organizations, American Academy of Pediatrics and OBGYN. This highlights the importance of ensuring that attention to DV and substance use coercion are factored into substance use treatment for pregnant women and their children, and into prevention and intervention policies related to drug use during pregnancy and neonatal abstinence syndrome. So again, looking at this together, the nexus of chronic pain, trauma, and the traumatic mental health effects of abuse and domestic violence, we can see underscores the importance of factoring all these issues, DV, substance use coercion, and gender-based violence, into the discourse on the causes and contributors to the opioid epidemic, the factors that contribute to addiction and pose barriers to recovery. Considering the role that substance use coercion may be playing in a survivor's risk for involvement in the child protective system and the criminal justice system, including being coerced into illegal activities, unwanted sex, or trafficking under the threat of forced withdrawal, it's critical to the development of DV-informed state and federal opioid policy as well. So where does this leave us? What are some strategies that we might be able to employ? First is for those of you who work in healthcare, behavioral health, and substance use treatment, is recognizing the prevalence and the impact of DV and substance use coercion on people's use of substances, their access to services, their relapse and recovery, and their risk for overdose, and to implement policies and practices that support attention to these issues. So that means incorporating conversations about DV and substance use coercion into your routine assessments, strategizing about safe ways to access treatment and services, addressing this as part of opioid treatment, relapse prevention and recovery support, as well as chronic pain management and partnering with DV programs. And here's the cover of our mental health and substance use coercion toolkit that was developed with my colleague Erin Tinnen and designed beautifully by Juliana Pino. That contains a wealth of material on exactly how to do this, and it's on our website, and we'll send this out with resources after the webinar. For DV programs, there's a couple things to keep in mind. One is our philosophy and stance, and while many programs are doing a wonderful job of addressing these issues, others we know are still struggling along a continuum from zero tolerance to don't ask, don't tell, to having a welcoming, inclusive harm reduction approach, and to having comprehensive and integrated services. So again, making sure that we recognize that the stigma we all carry is something that abusers are able to leverage to prevent their partners from accessing our services, and that both substance use and DV both present safety risks and health risks to survivors. This comes from our beloved Patty Bland, and it means really taking all of these issues to heart in our work. One of the things I have at the bottom here is that it's importance of advocating for services. We know in the SAMHSA's recent 2017 National Survey on Drug Use and Health that only 20% of people who need substance use treatment services get them of any kind, and only about 12% get substance use services, that specialized services. So again, as advocates, making sure that as opioid money comes through the states, that people have access to the full range of medication-assisted treatment options, that different options work for different people, and we need to have the full range of really comprehensive services that people can relate to that are part of the recovery process. The MAT and naloxone help keep people alive, and the comprehensive services help people recover. Holistic pain management is really critical, and resources and support to address disparities. And again, collaboration is key. So just a couple last points I want to make. Thinking about prevention, when we think about community opioid education and outreach initiatives and take-back programs, thinking about the role that DV and coercion may play in people's substance use is critical for being incorporated into any prevention efforts that take place in our communities. We also think about safer prescribing and opioid prescriber guidelines, not factoring in the role of chronic pain that abuse survivors experience and that some may need opioids, but also factoring out in having an abusive partner who may be trying to control their medication or divert them. Making sure that DV and sexual assault programs have training and survivors have training as well on overdose prevention and being able to administer naloxone, having safe spaces for people to be who are using to in shelters so that they can be safe as well, and incorporating awareness of domestic violence and sexual assault into community initiatives, safe, resilient, trauma-informed communities that haven't necessarily addressed these issues. Finally, I want to make sure that from a policy perspective, we're thinking about ways to ensure that DV trauma and substance use coercion are attended to in all opioid policy, public health, workforce and training initiatives, treatment expansion, and data collection, including maternal mortality reviews and public health surveys. that DV and sexual assault programs and survivors have access to the full range of resources that they need, that collaboration is really supported at the federal, state, and local policy level, and that state, territory, and tribal DV coalitions, FIPSA, and OVW administrators and local programs are involved in shaping opioid and substance use policy and practice in your states, territories, and tribes. So with that, I would love to hear more about your efforts to address these important and complex issues and to have you participate in our ongoing work in this area. And with that, I'm going to turn this over to you, Lori, if I can find the little ball.
Okay. Am I on? Yes. Okay. I have to move to the... Okay, there I am. Good afternoon, and thank you for being here. I'm going to talk just a little bit about what we see when we are talking about West Virginia. We know right now that it is the state with the highest rate of opioid overdose deaths in the nation. We're talking per capita, not sheer numbers. And though a report in January of 2018 showed that West Virginia had its biggest annual drop ever in the number of prescription painkillers being dispensed, but the number of fatal drug overdoses in the state continues to rise, and that has not changed. This is mainly due to an increase in the use of illegal opioids such as fentanyl and heroin. And we also continue to have the highest rate of drug overdoses in the country, more than double the national average. Additionally, West Virginia has the highest in number of babies per capita being born with neonatal abstinence syndrome, which is a critical issue. And there's so many other statistics, but this kind of gives you a snapshot of what we're dealing with here. However, we also know that the opioid epidemic is a national crisis, and what I'm describing is happening just about everywhere in our country. But we want to look at why West Virginia and other rural and Appalachian communities are being hit so hard at this time. There's a lot of conversation and research being done, and here are some of the thoughts around it. Number one is lack of access to substance use treatment programs. And we know, again, that's a critical issue around the country. But when you start to talk rural communities and also impoverished communities, there's usually quite a shortage of local services, both for mental health and substance use. A lot of people in West Virginia sometimes have to travel 2 to 3 hours to services. And if they go into a residential treatment program, oftentimes there is no follow-up afterwards. Additionally, there is the privacy issues and the stigmas in small communities. If you go to a treatment center, when services are there, everyone knows where you're going because it's such a small community. The other is if you can find a bed and then you have to go back to your community, you may end up with the same people and the same issues ongoing. So other concerns that we have found, too, is that with some of the local services, a person who is experiencing intimate partner violence may see the person who is abusing them in the same treatment program or going to NA or AA meetings. And there aren't many gender-specific or culturally specific services that are offered. We know about the stigma issue. It's a really big issue here. And advocates that are in the smaller rural communities said there's often a more traditional view of male and female roles, and that intimate partner violence is often viewed as a family matter. And women, especially women who have children, tend to be judged more harshly for using substances, they find, than males are, especially when you get into the courtroom. It's often viewed as a deficit in her character, that she's a bad mother, and is not offered the same excuses that may be offered to her partner. Transportation is another major issue. There's very little public transportation except in some small pockets like Charleston, Huntington, Morgantown, and a lot of people don't have access to a car, or if there's only one car in the family, the person who, and it's a family where domestic violence is present, the person who is the violent person in the relationship often is the person who has access to the car and has the car in their name. And talking about issues around transportation and the rural nature and the distance that people have to go for treatment, I've shared this story before, but I facilitate our coalition's Behavioral Health and Domestic Violence Initiative. And 1 or 2 years ago, one of the advocates who sits on this committee came running into the meeting late. Her hair was wet, and she apologized for being late. She lives about an hour and a half to 2 hours away from our office, but she does come for the meetings. She said she had gotten a call at 11 o'clock that night, had to drive 3 hours across the state to bring someone to a treatment program, a residential program. She stayed while the person got admitted, got into the bed, got all set, and then she ran home, took a shower, and ran to our meeting. So I really have to say I was so moved by how dedicated she and so many of our advocates here are here. One of the issues that we do have, too, in terms of isolation is that West Virginia is the only state in the nation to lie entirely in the Appalachian region. And that means we have very sharply sloped mountains with deep valleys hollowed out. And these valleys are often referred to as hollers, but you have one way in and one way out. And many areas don't receive phone or internet service because of the shape of the geography. You learn quickly where you can make a call, where you can't call, which is a real major issue for people who are trying to get help for intimate partner violence or for someone who is having a drug overdose, being able to receive help quickly. Telemedicine is starting to be used because there are some monies coming into West Virginia in the form of grants and various initiatives to address some of the issues, and hopefully we'll see the results of that in the near future. We all know about massive overprescribing. West Virginia has one of the highest rates in the nation of an aging population, and a lot of the work that's done is high-risk injury work, mining, logging, nurse aid, those types of things. And so when you are injured or you are a person who is aging and has pains and falls and things like that, you do end up getting a lot of prescriptions. And the other is that the mines are becoming more automated and the steel mills are gone, so that there are fewer jobs or no jobs present. And some people, if they have been using, they can't pass a drug screen, and so they can't get another job, and they sell medications. So that ties in directly into the insurance and money issues. One of the things we do see is a lot of despair, and you hear that all over the state. It's just one of the advocates from one of the most rural regions in the southern part of our state said that everybody, not just the domestic violence programs, are drained emotionally from the scope of the problem. She said it's overwhelming and has created a sense of community hopelessness. Just to give you a very brief description, we have 14 local licensed domestic violence programs in West Virginia, and all counties are covered. They have a catchment area, so we know that all the counties are covered. And these are some of the things that we are seeing. We have a very dedicated staff, but they can hardly find services for their own families, and much less finding them for people that they're working with. And again, you see what we have listed here: overwhelmed, frustration, guilt, sadness, and a lack of self-care, which is so critical when you're doing this type of work. And being asked to do rehab work, but that's really not their role. These are things we're seeing from women who are coming for help, that the main thing that they see more and more is if the children have been taken away, what they are trying to do is get their children back, so they go for services in order to do the work that they need to do to get their children back. Addressing the issues of domestic violence isn't necessarily a priority, and so there are a lot of issues around continuing to be in a relationship that is violent. So responding in domestic violence programs, there's so many different ways to respond. And when we begin that conversation around the role that the DV programs play, it's not only intimate partner violence, but also the various critical issues faced by those coming for services, as we know, including substance use. And so I'm just going to name a few things, a number of simple things. I'm not going to name everything that's being done. I know nationally, you go to any domestic violence program, you're going to find all sorts of wonderful initiatives. And I think if we can find a way to connect and share what's happening, such as this webinar, that's great. One of the most important strategies for addressing the issue of substance use, of course, is understanding trauma, having a deeper understanding of trauma and how it can impact substance use. One of the programs that went through the work to learn more about trauma and what was going on talked about the time there was a woman who was there, and her children were coming to visit. Her children had been removed, but they were coming to visit in a couple days, and she wanted to go get them some oranges because she knew her children loved oranges. And she ended up not coming back to the shelter until very late that night, and she had issues with using substances, and she came back and had been drinking. The shelter manager, rather than saying, "I'm sorry, you have to leave, you got to go," said, "Why don't we meet tomorrow morning at 11 o'clock and we can talk?" And when she showed up at the office at 11, the shelter manager said to her, "Can you tell me what happened?" And the woman described that she was walking down the street. She saw the partner that had been abusing her. She popped into a local pub. She knew some of the people in there, and she stayed in there. She was really frightened, and then they started buying her drinks, and she went along with it. And they talked a little bit then about using some of the strategies that Patty came up with, the mini safety and sobriety plan. They talked about options that she could do should a similar situation arise, and really work through how to do safety planning around using substances and seeing her partner rather than the strategy she had used. And she actually went on to be very successful in stopping using and eventually did get her children back. But that's what can happen within a program if you really start to understand that. It takes the education and training and services that are listed here. Most of our programs have had training in naloxone use, and so there is, and they have access in the shelter and in the programs. Some of the other things that we have is a behavioral health and domestic violence initiative here at the Coalition, and the push for the coming year is to have an advocate from each of the 14 programs represented on there. And in the past, a lot of our work has been outreach into the behavioral health community, and we really have started to reach back and be able to work directly with the programs. Another is that we have a grant that allows me to go for 2 days to each of the 14 licensed programs, and each one gets their individual 2 days to work on looking at initiatives and how to respond around substance use and mental health, and do a behavioral health, not just training, but really discussion and presentation of the tools. And that's been really very helpful. And thinking about doing group work, using some of the tools, the real tools, the work from Stephanie Covington's Seeking Safety, which you're going to hear about from Beth, all of these have been wonderful ways to do groups that are really intended for women who are using, to really work closely with them and to provide other options. Another thing that has been very valuable is not only self-care, but as I talk to two of our local, actually a number of our programs, but I want to highlight 2 of them. One is the program in southernmost West Virginia, in one of the most impoverished counties in actually the nation. And drugs are on the rise. Funding has been lost for a number of the special programs they were doing, including work with children. And so the advocates really pulled together and said, what can we do? And what they did was they realized women were coming in exhausted, as they often do, to the program, but these were women who were also using substances. They were sleeping till 1 or 2 in the afternoon, and part of it was boredom. They didn't have anything to do. So the women decided, the advocates decided to offer things such as cooking classes and different things like that, and having fun to bring people together, because they understood what we had talked about, that Carol mentions and Stephanie Covington mentions, that a lot of trauma and a lot of substance use creates a breach in connection, and they thought it's really important that we help people to be reconnected. And what they found was that they were starting to be more and more trusted. People were coming to these classes, having fun, sharing with one another, and women who were using started opening up about the issues that they were facing, asking for help, reaching out, and then also connecting with not only the advocates but other women there. It seems like a simple thing, but as Pat, one of the advocates, said, it can be just a simple seeming action, but it means so much to feel like you are seen for who you are. Engaging with other people in many ways, not just as an addict, can be life-changing. So using some of those simple techniques, but then connecting it back, because they now have started to do some groups using that type of work. One other that I'm going to highlight, and then I will close, is the Family Refuge Center in Lewisburg. Futures Without Violence has an e-newsletter, and the summer newsletter had an interview with our shelter manager, their shelter manager, who is just wonderful, Stephanie Keys. And here's a quote that she had: "If we did not allow people who use drugs to come to shelter unless they were sober, there would be literally no work for the shelter advocates to do. Our programs are seeing up to 75 and 80% of people who are coming who are using substances." So some of the things they're doing is offering rides to treatment centers. They ask that people not use while they're physically in the shelter, but they don't have expectations that they wouldn't be using outside. They participate with people utilizing the needle exchange and harm reduction programs, and they work really hard to make sure that all of the advocates are trained, understand what is going on. Another thing that they talk about is housing, and some of the hotels in their town now are no longer allowing local people to come and use the hotels because they're worried about drug activity, but it was the overflow place that was used by the shelter itself. And so they're going to try to work with the local hotels to find ways to continue to be able to use that when they're at capacity. So the common themes I see from all of the programs that I've talked to is that everybody is on board as a team. They help each other and support self-care. They use outside resources, and just there's a lot of work that gets done that might not be work that you might think about, but it's subtle, but it's very critical. And these are just some other initiatives. I'm going to stop now. Feel free to contact me, and I can talk to you about some of these, but I'm going to turn it over to Beth. Thank you.
Thank you so much, Lori. This is Beth Collins. I'm very pleased to be here today. I am currently with the State of Colorado Department of Human Services, and previously I worked at the Colorado Coalition Against Domestic Violence, where I was involved with the Seeking Safety Learning Circle. Advocates at anti-domestic violence organizations in Colorado consistently say that they want more tools to support domestic violence survivors who are experiencing negative impacts from substance use. And we know that safety and sobriety are very closely interwoven. Yet, advocates weren't necessarily trained on or comfortable with addressing substance use. So Seeking Safety, which has a strong base of research showing its effectiveness, was chosen for the Learning Circle project. So here you can see a map of Colorado, and the stars indicate the communities where there were advocates who chose to participate in the Seeking Safety Learning Circle. We did have 9 organizations from around the state who participated, and each organization sent at least one advocate to a one-day in-person training. And in addition, they committed to monthly teleconference discussions for 6 months. And in Colorado, we don't have integrated services to address domestic violence and substance use together. So in the Learning Circle, we were trying out a treatment tool, but in an advocacy setting. We know that advocates are extremely knowledgeable of local resources. So just to extend on what Lori was already covering, advocates are locally based, they provide free services and legally defined confidential services. Advocates provide an individualized response across a wide span of batterer-generated and life-generated safety concerns, and they can help connect survivors with civil courts, children's services, housing supports, so many different things. Our Learning Circle participants were all community-based anti-domestic violence advocates. The starting point for our Learning Circle was that all group participants would be people surviving domestic violence. And just to ensure that we're all on the same page, domestic violence occurs when a person uses a pattern of coercive behaviors to dominate decisions about a relationship and to control aspects of their partner's behavior. Survivors of domestic violence come from all backgrounds, and the tactics of coercion will be individually tailored to create and exploit vulnerabilities that allow the abusive person to maintain control. Tactics of abuse against a parenting transgender woman who's a professor in an urban community are likely to be quite different than the tactics of abuse that are used against a non-parenting cisgender Latina who's working as a nurse in a ranching community. But we know that across such variation, batterer-generated risks will persist and even intensify as survivors attempt to gain independence and self-determination. Batterers routinely sabotage help-seeking and use survivors' struggle for sobriety against them. And while all of us face life-generated risks to our own personal well-being, which could include financial insecurity or health conditions, racism, heterosexism, and so on, for survivors, these life-generated risks will also be amplified intentionally by their abusive partner. So, as to the Learning Circle activities, each participating advocacy organization was provided with the Seeking Safety curriculum in English and also in Spanish if the participating advocates were bilingual. The organizations each agreed to provide the participating advocate with time to read the first 2 chapters of the Seeking Safety manual, to attend a one-day in-person training, and then to join 6 monthly teleconferences for the 6 subsequent months, and also to offer at least 6 sessions of Seeking Safety locally in their community. So here we see a quote from an advocate, and as many of you no doubt know, anti-domestic violence advocates are very busy, very practical, and they are absolutely dedicated to survivor empowerment. So we knew that advocates would critically evaluate any new tool that they provided. So we were really anxious to get feedback from the advocates. What did they think about all of this? And the spoiler alert is that the project was a success. Across the board, advocates loved using Seeking Safety. People surviving domestic violence can join a Seeking Safety group at any time because it does not need to be a closed group. Each session focuses on learning a skill to help manage the stresses, and it encourages each participant to think about how the skill that's the topic for that session might relate to their own specific situation and how they themselves might use it. Seeking Safety works for people who have a variety of tension-reducing behaviors. So thinking about substance misuse as a tension-reducing behavior, the groups that were offered in Colorado did include people who did not identify as having substance misuse concern, but who did identify that they participated in other types of tension-reducing behaviors. And that's one of the really lovely things about Seeking Safety, is that it is very widely applicable and very flexible in its adaptations, as we'll talk about in another minute. So one thing that's great about Seeking Safety is that each session follows a predictable format, which is trauma-informed. So each session begins and ends in a predictable, low-intensity way. And the discussion that happens in the middle is where it's possible that a person, might be talking about something that's a little bit more intense, a little bit more personal, and bringing up more emotion. But this format of having this session intensity curve, it helps participants to be in an emotionally grounded place when they leave the session. If you are considering the setting where you work and wondering if Seeking Safety could possibly be a fit, please note that Seeking Safety is incredibly flexible, and Learning Circle sites use Seeking Safety in a variety of ways and in a variety of settings. So we did see that it was offered as a closed, open, or drop-in. It was offered on various days, different times of the day, different frequency intervals, different locations, different targeted populations of domestic violence survivors, and it worked very well in all configurations. And across all the Learning Circle sites, even with all of that variety, the feedback from the participants was consistently positive. The in-person training that advocates in the Learning Circle attended focused on the topics that you see listed on this slide here. Seeking Safety compassionately addresses the connection between trauma symptoms and substances. Many survivors do not know how trauma exposure can lead to distressing post-trauma symptoms. And they don't know how that then leads to coping, and how coping that is actually working pretty effectively can turn into coping that is no longer working well, or that is starting to accrue a lot of negative secondary impacts. In addition, as we talked about, these issues, both the trauma and also coping through substance use, can be incredibly hard for people to talk about, given that they are both painful and highly stigmatized. The Learning Circle helped advocates feel confident in not only talking about substance use, but also explaining to people the link between coping and providing alternate ways for them to manage how those trauma symptoms were coming up for them individually. And when survivors understand this linkage between the things that they've experienced, how it's impacting them even now, and how the substances tie in, and they can discuss that with somebody in a non-judgmental way, feelings of moral failure or worthlessness can be replaced by hope. So, is Seeking Safety a good fit for advocacy organizations? In a word, we would say yes. And certainly Colorado was not the first to use Seeking Safety in advocacy settings. Advocates in California, West Virginia, and other states had successfully used Seeking Safety before we started our Learning Circle. This curriculum also, I would note, is very low barrier for advocacy organizations. So Dr. Najavitz herself states that the only required preparation, there's no required training curriculum, but the only required prerequisite is that she says, go ahead and read the first 2 chapters of the curriculum and then try it out. So the curriculum can be purchased for about $50. So this is another real value of this particular curriculum, is that it's easy to obtain, and it can be pretty quick to actually begin trying it out at your organization. So we've discussed that seeking safety is a strengths-based and compassionate curriculum. And we know that it allows substance use to become part of a larger conversation that advocates are having with survivors about their safety and well-being. And the expertise in safety planning that advocates have is tremendously important in addressing substance use coercion and how an abusive partner might actively try to sabotage the survivor's sobriety and skills and their attempts at additional help seeking. So it's not only dealing exactly with the trauma symptoms and dealing with the substance use, but it's also talking about how is the partner or ex-partner perhaps attempting to sabotage in both of these domains. I note as well that even as seeking safety led advocates to feel more effective in their work, advocates overwhelmingly said that the ideal would be that they would have closer linkages with their local treatment providing agencies. So for example, there was a lot of interest in perhaps co-facilitating groups and advocates, as was mentioned earlier by Lori, they didn't really want to get pulled into, being thought of as substance abuse treatment counselors. No, they wanted to do this work as an advocate, but they were very open to additional partnership with people with expertise in substance addiction. The coalition did ask advocates about their experience in the project, and we were pleased to hear that the training, becoming familiar with the Seeking Safety curriculum, and the monthly Learning Circle conversations did have a positive impact on their advocacy work. So here we can see that 80% of the advocates who participated identified that their participation had changed the way that they were engaged in conversations and showing up with and understanding the people that they were serving. If you are interested in more details about this project, you are welcome to download the full final report that is on the coalition website. So there is a link there. That link will work. I also note that the Colorado Coalition Against Domestic Violence has recently changed their name. They are now Violence Free Colorado, so you can find them by searching either term. So thank you all for your time and interest, and special thank you to Carol and the staff of the National Center for their ongoing support of all of our efforts here in Colorado. And I will now pause to see if we may have time for any questions.
Hello. So we just have questions, and I know that some were answered in the chat box, but I'll ask the first one. How do we help other residents who are also in shelter that may be triggered by another resident using?
Well, this is Beth, and I will give a brief answer to that. So from our perspective, we agree with what Lori was saying, that we're not really a big fan of zero tolerance in terms of if somebody has been using that they need to be asked to leave a shelter setting, but rather that advocates should respond to behaviors. So if somebody were to arrive back at a shelter and they appeared to be intoxicated or high, asking them to go in their room, something like that, like let's talk tomorrow, as was mentioned. And then if somebody's behavior is really leading to a safety concern, then you're addressing that safety concern that is being brought up by the behavior. So whether that behavior is manifesting because a person is using a substance or not, having a similar type of response in terms of how the advocate would approach that. So in our experience here in Colorado, advocates have really benefited from having more support around how to have a conversation about substances and being able to talk with other residents in the house about their triggers and their options. But I will check and see if Lori has more to add on that as well.
Just to save some time, Beth, some people have asked regarding Seeking Safety, is Seeking Safety workbook more of a therapy type book or educational type? Does the DV advocate need a therapy license to use the book? And also, is it being used on reservations? I know this is a loaded one, and the Navajo reservation in particular.
Awesome. Great questions. So originally, Seeking Safety was written to be facilitated by mental health clinicians. However, Seeking Safety is more evidence-validated than any other treatment intervention, and it has subsequently been found through research evidence to be effective when facilitated by substance abuse treatment counselors, paraprofessionals, advocates, and also when it's peer-led. So no, you do not need any particular training or therapeutic background or licensure, no. Anybody who has an interest and who is willing to read the book and become oriented to the model would be endorsed as an appropriate person to help lead a Seeking Safety group. I think it would be fantastic to see it co-led by an advocate and a survivor, but that's just me. And as far as some of the other questions, I don't know specifically if it's being used on the Navajo Nation. I do know that it's written for clinicians, so sometimes the language can be kind of therapeutic, and that was part of what the participants in the Learning Circle found useful, was to get advocate feedback about how to make small changes to some of the language that they were using that felt more comfortable in an advocacy setting and felt less mental health therapist-like. And also, it is written specific to substance abuse, but as I mentioned, it also has been validated to be effective for people with other types of tension-reducing behaviors, and so that's another modification that can be made, is to shift some of the language to talking about tension-reducing behaviors rather than always anchoring specifically on substance abuse.
All right. Thank you so much.
Can you hear me? This is Lori. Can you hear me?
Yes.
Oh, I tried responding before, Beth, and I don't think I got through, so I'm glad you can hear me now. I did a training with Lisa, training of trainers type thing in spring, and I think it's really a wonderful tool and would strongly endorse it. In addition, just to answer a few questions about who can do any of the models, Patty Bland's Real Tools is set up in a similar fashion, designed for a peer-led type of group where people can drop in and drop out within the in domestic violence program setting. I think that Seeking Safety is really more, designed for a variety of settings, and Patty's really focuses deeply on the domestic violence program setting. The work of Stephanie Covington is also really wonderful to address issues related to trauma and substances, but hers tend to be a one that's more prescribed. You need to, like, one of them is a 11 or 12 session, another is 5 or 6, and it's intended to build on it. So that too, Stephanie and Patty both were strong believers in that it's a person who understands the material, has the heart to do the work. But hers, Stephanie Covington's, are you really kind of need to attend all 11 sessions, or all 6, or all 5. So they're all different models, and I think they're all excellent. And thank you, Beth, for sharing Seeking Safety. I was glad to hear about it myself.
Also, as Carol, the one thing Stephanie talks about, and I think, Beth, you've talked about this too, is that what's recommended is that you actually go through the sessions yourself as a participant before becoming a trainer, and that's one of the things that's most helpful in grounding you and being able to do those groups.
Okay, and I think with that we've run out of time, so I would like to thank Carol, Lori, Beth, and Christina for today's webinar, and thank you to Angelica for making the webinar run smoothly. Last but not least, thank you all for spending your time with the Center. Within the next week, you'll receive a follow-up email with the link of today's recording in addition to the slides and handouts referenced, all of which will be available on our website. You will also receive a certificate of attendance for your time today. And at the very end of the webinar, you'll be taken to a brief evaluation. If you could please take a moment and let us know what was useful and what could have been better, it would be greatly appreciated. Thanks again, and we all hope that you have a wonderful afternoon.